Thank you for coming to our first Congressional Capitol Hill briefing that we've ever held here, and so the attendance here is great for us. I've been here talking at other people's briefings, but our organization is now holding its first, so I just wanted to welcome you all to it. My name is Twila Brase. I'm president of Citizens Council for Health Freedom, and we are a free market healthcare policy organization located in St. Paul, Minnesota. And we do state healthcare issues when the legislature there is in, and we do national healthcare issues all year long. So there are several things that we deal with on a regular basis that don't relate to the Minnesota legislature, but just relate at the national level. Our vision is securing health freedom for all, and our mission is to secure patient and doctor freedom, medical innovation, and the right of individuals to a confidential patient-doctor relationship. So today we're here to talk about the topic prevention and wellness. Who is responsible? So what I'm going to do is I'm going to speak first about the details within the federal healthcare reform law, and including the costs and their impact on privacy and autonomy. And then Dr. Alida Eck, who is a physician and who is the president-elect of the Association of American Physicians and Surgeons, is then going to speak from her perspective as a physician with regarding the prevention and wellness pieces of the law and what that means, transitioning essentially from the individual being responsible to employers, government, and health plans being responsible for prevention. So at the end of that, then there'll be time for Q&A, for questions and answers. So we will take your, probably that'll be in the last 15 minutes. So just let me begin by saying that what you probably know already, because here you are in Washington, D.C., is that Secretary Sebelius has announced that this month, June 2011, is the first ever Prevention and Wellness Month. And so this is a new proclamation. I'm guessing that every June thereafter is going to be Prevention and Wellness Month. The second thing that is new is that Congressman Eric Paulson and Senator Amy Klobuchar, both from Minnesota, where our organization is located, announced the establishment of a Congressional Wellness Caucus to focus on workplace wellness. This was an initiative, by the way, that came out of the business community and the health plan community in Minneapolis and St. Paul. These initiatives likely stem from the prevention and wellness components of the federal healthcare reform law, which was enacted last year. Preventive medicine, or preventive medical care, according to the CBO, includes services such as cancer screening, cholesterol management, and vaccines. And wellness they define as efforts to encourage healthy eating habits and exercise and to discourage bad habits, such as smoking. Well, during the year-long debate over healthcare reform, prevention and wellness were not hot topics. They're not something that the news really covered. But I think given the breadth and the comprehensiveness of the initiatives, I think they should have gotten more attention. The provisions essentially make staying well and keeping citizens in good health the legal and statutory responsibility of the federal government. The provisions encourage and in some instances require a shift of responsibility for preventing disease and injury from individuals to outsiders, such as doctors, employers, and government workers. The mentions of related words in law demonstrates the level of importance given to these initiatives. Prevention is mentioned 233 times, wellness 91 times, preventive 108 times, lifestyle 16 times, behavior 72 times. The requirements are many, and I'll list a few, many of which are in your handout, but I'll have just a few more words about them. So health plans must engage in wellness and prevention, including health risk assessments and interventions, and they must report annually on their efforts to the federal government. This is an unfunded mandate that will lead to increased premiums. The law also sets up a National Prevention, Health Promotion, and Public Health Council, requires a national prevention strategy to be issued, and establishes a new Prevention and Public Health Fund. The federal government will create a website for individuals to determine their disease risk based on private health information disclosed by citizens online. Medicare recipients will get an annual wellness examination that includes a health risk assessment. And this morning, Alida was looking at her phone and noticed that there's a new ad campaign that HHS just announced this morning when we were looking to see what the cost of it was, but we couldn't find it. Then the ad campaign is regarding that annual wellness and encouraging citizens or Medicare recipients to get it. In addition, communities will be measured for behavior, weight, and physical activity, and the current oral health surveillance system will be expanded to all 50 states. Electronic medical records will be used in Medicare to monitor and improve adherence to provider medical recommendations. Grants will be provided to promote health behaviors and to conduct ongoing health screening of individuals between the age of 55 and 64 to identify their risk factors. And the Secretary of HHS will evaluate workplace prevention programs and federal health and wellness programs. There will also be technical assistance for employers to engage in wellness and prevention activities, including evaluating changes in employee health status, absenteeism, productivity, injury, and medical costs. Finally, grants will be given to small businesses to provide comprehensive workplace wellness programs that include screening, health risk assessments, initiatives to change unhealthy behavior, as well as initiatives to increase and encourage healthy lifestyles, eating, exercise, and mental health. Now, this is not an all-inclusive list, and you can go into the bill and look, and if you look on your handout, you'll see that the actual citations or the sections of the bill regarding many of these are in your handout, so you can look at the language and see, but that's only just a piece of what is in that language. Well, there are significant costs related to these provisions. Costs include real dollars from taxpayers, higher premiums for the insured, a loss of individual privacy, and interference with personal and professional autonomy. So I'll discuss privacy and autonomy first. And as a baseline, I just want to talk a little bit about HIPAA, because people have this sense that HIPAA is a privacy law, and it's called the HIPAA privacy law, but it's not a privacy law. We call it the no privacy law. It's because what it really is a disclosure rule. I'm sorry, HIPAA privacy rule. But it's a disclosure rule. And if you look when you're at your doctor's office next time and you're asked to sign that little paper that says that you have read the Notice of Privacy Practices, read the Notice of Privacy Practices. If you read the Notice of Privacy Practices, you will discover that there is no privacy, that your information can be disclosed to lots and lots of people without your consent or without your knowledge. So the only thing that you're doing when you're signing that piece of paper is saying that you've read it, and essentially that you understand that you don't have any privacy. A lot of people think that when they sign it, they're signing it to say that their medical records are between them and their doctor. But they're just signing it to say that they've read the Notice of Privacy Practices. And that means, if you've really read it, you know you don't have any privacy. So that's a really important thing to understand when I talk about privacy and I talk about autonomy in the clinic. You don't have it. So I wanted you to know that as a baseline of understanding. I forgot to say as well that the a federal regulation that came out in August of last year made it clear. They listed all the entities that have access to medical records without consent because of HIPAA, but also because of the HITECH Act. So the HITECH Act added all the business associates being able to have the access. So when you add them all up, you end up with 2.2 million entities that have access to medical records without the individual's consent or knowledge. So you just have to understand in all of this that when we're looking at prevention and wellness and we're looking at gathering all this information about people and their health status, their lifestyle, et cetera, that there is no privacy and that this information can be looked at by lots of people and used by people without the consent of the individual. So in that arena where government is having access to the data, government is one of those who gets access to the data, one of the 2.2 million entities. One thing that we're coming to realize is that doctors and patients no longer have the freedom to just do as they wish without the threat of a reprisal. So a mom came and talked to me maybe about a month ago and told me about the fact that she had been into the doctor's office with her daughter, her 12-year-old daughter, and the doctor wanted to do the Gardasil, the vaccine, and the mother said no. And the doctor looked at her and said, well, because you're not willing to do that, you're going to make my scores look bad. And what you may or may not understand is that doctors are being scored on their compliance with certain government-issued and HMO-issued protocols. And quality reports are coming out. Minnesota just did their first quality report on all the doctors in the states. And that's one of the things they look at is how much of the population is vaccinated in your clinic. And if insufficient numbers are vaccinated, the percentage is too low, then you get docked, and then you're a lower quality provider. So now the pressure is on both the doctor side and the patient side to do whatever is on the protocol. So what you have to realize is that as HHS begins to monitor, track, and measure compliance with these protocols, the pressure is on for the doctors to do exactly what the government or the HMO or the two of them together say is what needs to be done. This will include prevention and wellness services, which brings me, because we're talking about prevention and wellness specifically, brings me to the U.S. Preventive Services Task Force. The federal reform law says the following in section 1001. Nothing in this subsection shall be construed to prohibit a plan or issuer from providing coverage for services in addition to those recommended by the United States Preventive Services Task Force, or to deny coverage for services that are not recommended by such task force. Well, I look at this statement as a bit of political theater. Following the task force's recommendation is already impossible, and HHS knows it, but yet it was written into the law. 3 years ago, an evaluation of the task force by the Agency for Healthcare Research and Quality shows that the government can be out of sync with the realities that are happening in the exam room. One of the agency's own clinical advisors said the following, and is reported in that report regarding the Preventive Services Task Force recommendations. Quote, if you actually took the time to do all of the preventive services with every patient and have all of the necessary conversations and address all of the concerns necessary, you would be working 18 hours a day. A lot of the practitioners said it was impossible to do all the services that are recommended by the task force. Others commented on patient resistance, saying that patients typically have their own agendas and priorities when they enter the exam room, and it is difficult to turn the discussion to preventive health, especially when the doctor only has 12 minutes or less with a patient. Okay, but even if it were possible, would prevention actually save money? Oftentimes, no. In a 2009 letter to Congressman Nathan Deal, CBO Director Doug Elmendorf writes, although different types of preventive care have different effects on spending, the evidence suggests that for most preventive services, expanded utilization leads to higher, not lower, medical spending overall. He writes that the ultimate savings would offset only about 10% of the cost of preventive services on average. And regarding wellness, Mr. Elmendorf says, designing government policies that are effective at inducing people to be healthier is challenging. Even successful efforts might take many years to bear fruit and could involve significant costs. Mr. Elmendorf's comments concur with a 2008 article in the New England Journal of Medicine, which stated, although some preventive measures do save money, the vast majority reviewed in the health economics literature do not. Despite the CBO's admonitions, last year's congressional leadership decided to pour mandates and money into prevention and wellness. Our handout shows a portion of the dollars being required from taxpayers, many of them left open as blank checks into the future. So last week, you may know that the HHS National Prevention Strategy was announced to comply with the federal law. Its comprehensive view of federal intervention in private lives is troubling, and it portends extensive federal spending to come. According to HHS, and I quote here, the strategy recognizes that good health comes not just from receiving medical care, quality medical care, but from stopping disease before it starts. It notes that good health comes from clean air and water, safe outdoor spaces for physical activity, safe work sites, healthy foods, violence-free environments, and healthy homes. Furthermore, it states, prevention should be woven into all aspects of our lives, including where and how we live, learn, work, and play. This is truly all-encompassing. Nothing and nowhere is left outside the grasp of what government is planning to impact. It sounds like a search, essentially, for, I don't know, kind of a health and wellness utopia. Given its comprehensive nature and the law's blank check of such sums as may be necessary, and that's written on your handout, and I think there's probably more instances of that, but at least you've got several of them. Given its nature and the such sums as may be necessary, we believe that the national prevention strategy will divert significant healthcare funds away from those who are ill, injured, suffering, and dying. Indeed, the overview says the national prevention strategy, quote, helps move the nation away from a healthcare system focused on sickness and disease to one focused on wellness and prevention. Now, I'm a nurse, and I know there will always be sick people. From the dawn of time, there have been sick people, and that's why we have doctors and nurses in hospitals, because there was a need to take care of people. Injuries happen. We cannot prevention our way out of illness and disease, and we cannot wellness our way out of death and dying. These are things that we will have to live with forever. Our organization is very concerned about the federal government shifting significant healthcare resources away from the treatment of illness to the prevention of illness. This is likely to be cold comfort to those in need of cures, care, and compassion. One of our concerns is whether or not we will come to a time where patients will feel like they are a burden to society. They will feel like they've not somehow completed their obligation to stay healthy and well, as the government would like them to do. We are also concerned that HHS takes the position that government must act to assure a healthy population and that everyone, including health plans, communities, taxpayers, and employers, is responsible for, as they say, creating a healthy nation. Prevention and wellness ought to be for the purpose of individual health, not the health of the nation. We believe this national prevention strategy goes far afield from the very limited powers of our constitutional republic. The best strategy for health and wellness would be to give citizens a reason to care about being healthy, to the extent that their body, their DNA, and their circumstances permit. Some people, it just won't happen. It's how they're built. And that reason is their pocketbook. However, the federal healthcare reform law moves away from the power of the pocketbook. It expands entitlement, leaving more and more individuals more dependent on government with less reason to care about their health, and then tries to force them through practitioners, employers, and tax-funded programs to act in ways that only the unentitled act, which is to think about the money that they're going to have to pay out of their own pocket. I will conclude with 3 suggestions that will encourage health and wellness while still retaining our constitutional freedoms. Number 1, we need to bring the pocketbook back to healthcare. This means cash, check, or credit cards, and there are examples around the country where this is starting. There's even a surgical center that is cash only, no insurance, no Medicare. It's about 1/3 the cost of the hospital up the street. It also means that there would be far less paperwork to pay for, and therefore the cost can come down. So the prices of today do not have to be the prices of tomorrow. Number 2, we need to restore health insurance to true insurance. Today we have prepaid health care for every medical need, from the sniffly nose to the comatose patient. We need to move away from expensive entitlement-based managed care, including employer-sponsored coverage, so that we individually own our policies. And we need to rebuild true health insurance, preferably defined contribution insurance, which gives people money and sends them out shopping for the best deal and the best doctor that they can find. So all minor routine and preventive care should be funded by cash, credit, check, or health savings account. And the last one, we need to repeal the healthcare reform law, not only to repeal the expected diversion of healthcare dollars into prevention and wellness and away from patients, but also to repeal the prohibition against catastrophic insurance, and to repeal the power given to the Secretary to tell us all what kind of benefits we have to buy. So in conclusion, how healthy and how well a person wants to be is a personal decision of each individual. Some will find it difficult, some will find it easy, some will find it impossible, because of their genetic makeup, their family structure, their preferences, and their work schedules. Some will never care, regardless of the circumstances. But bottom line, we endanger our liberty when we empower government with the dollars and legal authority to make sure that we're all healthy, to monitor, to coerce, to control. We also move toward a future where disease and injury are not tolerated with the same care and compassion that this nation has long been known for. So government will never succeed in driving out sickness and disease, because they are a part of our lives. But the process of trying, I worry, may cause us to lose our privacy, our personal autonomy, and our amazing and caring medical care system, as well as the individual freedom that is the heart and soul of this great country. Thank you very much. Thank you. And now I'd like to introduce Dr. Eck. Dr. Alida Eck MD graduated from Rutgers College in New Jersey and the St. Louis School of Medicine in St. Louis, Missouri. She studied internal medicine at Robert Wood Johnson University Hospital in New Brunswick, New Jersey, and has been in private practice with her husband, Dr. John Eck MD, in Piscataway, New Jersey since 1988. She's been involved in healthcare reform since residency and is convinced that the government is a poor provider of medical care. She's testified before here in Congress about better ways to deliver health care in the United States, and she and her husband founded, now this one I'm going to have a hard time with, Zarephath Health Center, a free clinic for the poor and uninsured that currently cares for 300 to 400 patients per month, utilizing donated services of volunteer physicians and nurses. Please welcome Dr. Alida Eck.
Thank you. It's a pleasure to be here. It's nice to see such a good turnout of people who are really interested in prevention and wellness. When I started to think about this, I was asked last week to come and talk about prevention and wellness and my experience as a doctor taking care of real patients. I thought about this accusation that doctors get all the time. You always focus on treating disease rather than preventing it. Or, we have a sick care system, not a health care system. And I thought, yeah, that's probably true. When I went to medical school, I learned all about diseases and how to diagnose them and how to treat them. So I suppose people need to come to me when they're sick. But when did it become politically correct for the doctor's role to be sort of like the health instructor of your high school, to tell you all the things you need to do to stay healthy? And to remind people that they need 8 hours of sleep, don't forget to wear your seatbelt, don't forget to get your, eat the right vegetables and exercise and all that. And it does take a lot of time when I really need to be focusing on somebody who's got symptoms and signs of illness and to figure out what it is and to help them get better. We shouldn't waste time repeating all those same platitudes over and over and over because the limited time that we do have with a patient, which we have to do because it is the human condition to prefer indulgence over discipline. It just is the human condition. How many people have bought exercise bikes and there they sit in the basement and they become really good racks to put your, to dry your clothes? Or, I mean, it's just the way it is. We just don't like to have to do those things and exercise. Or we pay for a gym membership and we just don't go that much to make it worthwhile. Or how many people can't stop smoking? In fact, there are people who actually tell us they'd rather die young than stop smoking. That's just what they say. And you can't get them to stop, and you try and you talk to them and they know, but they can't. Or how many people have trouble just turning down one more cookie? You know, it's hard. It's just the human condition. Now, in the 1970s, there was something called the HMOs, Health Maintenance Organizations, that came out that it was under Nixon, and he thought, well, if we keep everybody healthy and maintain health, and so we pay this organization a certain amount of money, they focus on wellness, and people will stay well, and they'll see the doctor regularly, and therefore all the healthcare costs will go down. And what they did was they poured lots of federal money into these HMOs. And I remember when I was in a residency at Rutgers at the time, the Rutgers Community Health Plan was one of those closed HMOs. And those doctors had more time than ever to teach me. They just were really relaxed, and they just kind of, they were all getting paid a salary, no matter how many patients they saw. And it was supposedly a health maintenance organization. Patients loved it. They go to the doctor any time, and it was all in one roof. And if they need an orthopedist, they go down the hall, they see it. Trouble is, it was this federal money that was poured into it. And when that money dried up, because they didn't want to spend money on that anymore, the premiums for this HMO went way, way up, and it folded. So that didn't really work out. It just cost the taxpayers way too much money. It was a hidden cost. Well, now we have in the 2010s under Obamacare, they're going to want to, they call them accountable care organizations. And it's the same idea. But doctors need to fear these because they're making us accountable for those people who don't eat right. For instance, a diabetic, there's a test called the hemoglobin A1C, which we test diabetics. It gives us the average sugar over 120 days. They come in every 3 months. They can get this test done. And if it's high, it means that all along the way they were eating extra cookies and they weren't taking their medicine or they weren't exercising and it wasn't under good control, the diabetic. And you teach them and you explain what to do and they look at you and they're going to do whatever they want. Is that our fault? Is that the doctor's fault? Yet with the Accountable Care Organization, it's going to be made our fault. And they have a thing called gain sharing. If we save the system a lot of money, we can keep this gain. But then they'll lower the amount that is given. And on the other hand, if people do poorly, they can dock us. So it becomes the doctor's fault. And guess who becomes the enemy when these people aren't really doing what we're asking them to do? A non-compliant patient. I heard in Florida, there are doctors who refuse to do obstetrics on a patient who's very overweight. Why? Because the outcome might not be so good. It's hard, and things could go wrong. Doctor doesn't want to get sued. Forget it. I'm not going to take care of a really sick patient. So when you have doctors who are afraid of a really sick patient, or patients who have their own demons for reason why they don't do the right thing in their own best interest, and they become the enemy, that's really a bad system and something we ought to question. Same thing with COPD, chronic obstructive pulmonary disease, which is mostly caused by smoking. Again, people have bad outcomes. Is that our fault? They have more heart attacks. We keep the cholesterol down if they take the medicine, but if you only see them every 3 months, how am I sure that somebody's really taking the medicine? How am I accountable? We go to medical school for 4 years. We go to residency to 3 to 5 years. And we learn how to recognize disease. We need to treat disease. We need to not be afraid of a sick patient who's going to, be somebody that the government's going to look at as somebody who makes our numbers go down. And that's what the insurance companies want to do. Well, primary prevention is what I call real prevention, and that's just doing all the right things. That requires 24/7 vigil, and that requires every patient to take on their own responsibility to do all the things we know will keep us healthy. And that's primary prevention. That's taught in school growing up. It's taught by the health instructor. It's taught by the school nurse. Taught by your parents, your community. Primary prevention. And by the time you're your age, you know most of the things that you need to do. Then there's early detection, which I think sometimes gets confused with preventive care. For instance, a mammogram. What is a mammogram? A mammogram doesn't prevent breast cancer. No, what it does is it catches it very early when it's very treatable. That's a very smart thing to do. But women over 40 ought to start getting mammograms once a year. And do you know what the free market has done with mammograms? I don't know. Do you have any idea what a mammogram costs? Just throw out a number. What do you think? 2,000. Anybody else? 150. Big difference. Anybody else? What does a mammogram cost?
The guys are like,
whoa, who knows? There is a radiology group in New Jersey that will do one for $80. $80. Why do you need an insurance company to pay for something that costs $80? It's like an oil change. You just do it. You need a doctor's prescription to get a mammogram, and that's probably not the smartest thing. I think you ought to be able to just go get a mammogram and then tell what doctor to send the results to. But that's the way it is right now. So when you run that through insurance, you make that insurance policy cost a whole lot more. Blood cholesterol, that's a good thing to prevent. Heart disease, so go ahead and get that checked. Blood pressure checks regularly. Colon screening, that's another one that, you hear about cases of people dying of colon cancer, so we learn that you need it. It's a slow-growing tumor, so every 10 years on a person without a bad family history, you ought to get some kind of colon screening to be sure that you don't have early colon cancer. But the question is, when you make this into law, that the government is saying this has to be provided for everybody, whether they have insurance or not, whether they're in Medicaid, whatever, that is then putting the responsibility on somebody else. And I can write a prescription for somebody to get a colon screening, or I can just tell him you need to go to this doctor, they'll do it for you. And if they don't go, whose fault is it? I know a doctor right now who is getting sued for a guy who's 78 years old, came down with colon cancer a couple of years ago. The last time that doctor saw the patient was 18 years ago. The doctor is being sued for not recommending colon screening. What kind of nonsense is that? Because if they had had cancer back then, 18 years ago, it would have manifested itself a whole lot sooner than that. So they definitely didn't have it back then. But they're just suing that doctor. That's the whole litigious society that we live in. And now you add the force of law on all these preventive things, medicine becomes a very dangerous field to be involved in. So what I'm saying is that what we're doing with this new health insurance law, Obamacare, is we're shifting the responsibility from the patient to the health plan and the physician. And it forces us to buy insurance, which is way too expensive, because when you're adding all of these things onto the cost of your health insurance, the insurance costs more. They're adding, like, say, now you can get colonoscopy without the copay. So as if the $20 is the reason why people aren't getting colonoscopy. I can't tell you how many people I tell them, you know, you really need to get a colonoscopy if you're of the right age. And they go, I'm not doing that. It's just not the most pleasant thing. So they still have to be convinced that it's the right thing to do. And the $20 is not what's keeping them from getting it. And it forces the taxpayers to pay too much for it. What's happening then is that the paycheck goes down. Every time the premiums go up for health insurance, if your employer's paying for it, it's coming out of your paycheck. So your paycheck is lower. Everything we do in medicine then causes the insurance to go up. If your paycheck goes down, what happens? You have less chance to do what you really need to do for your family, and it's not a good thing. And again, the privacy, I mean, that's a huge thing. With this electronic medical record, it's going to be bad because there's going to be, everybody's be able to go into these records and find out what you had done, what you didn't do, you know, and then whose fault is it? Usually it's the doctor's fault. Or maybe it's going to be the patient's fault. You didn't get it, you know, what are we going to do? We're going to round you up and make you get it done because the government is assuming responsibility for your health. It's really not the free country that was when it was founded. Who should be held accountable? Say the person. But then maybe it's a team approach. Maybe his family ought to be saying, hey, you ought to get this done. Or maybe the church ought to be helping you to hold you accountable. You know, stop smoking. I know you see you're really having a hard time there. Maybe we could have a support group help you. All this doesn't have to cost a lot of money, but it's just a way. I gave you a book. This is sort of a defensive book that I wrote it, and I give it to all my patients, so they can't say I didn't tell you. That's one of the reasons why I do it. But really, I want people to do the right thing. And it tells you how to stay healthy, what you need to do. It tells you about the early detection, and I find it's just an easy way for me to have to say the same thing over and over to people and really waste a lot of time when they're coming in because they've got a cough or they've got abdominal pain or something else that I really need to be focusing on. And I also have here something that I think is going to be one of the keys to lowering health care for everybody. And this is something, initiative that we got started in New Jersey called the Volunteer Physicians Protection Act. And we're thinking about ways to lower the cost of health care for everybody by lowering the cost of the Medicaid system for the poor. What we did when we started this free clinic 7 years ago, we see people, they come in, it costs them nothing. But they come in and usually they're poor, they're scared. They tried to get Medicaid and they couldn't get it or for one reason, or they got Medicaid and they couldn't find a doctor, so they come into our clinic. But what we have is volunteers who come and talk to them, find out what it is that really makes you poor. Why are you struggling? What's hard? Did you make bad choices? Bad relationships, you know, which nobody can prevent. You can try your best, but sometimes you find out that you just married somebody you didn't know and you wound up in big trouble. Or you started drinking too much. All the vices that we're talking about with prevention. But if you had somebody come alongside you and say, I want to help. I can help you with this. Like I had that kind of problem. And there's a group, a support group that had that. That is the type of prevention that's really going to work rather than seeing a doctor every 3 months. And that's the type of thing. In fact, it was really funny because I was thinking last night about this, and there's a verse. I called my husband, where did this verse come from? This is in the Bible, in Matthew 9. It's not the healthy who need a physician, but the sick. Oh, that is really the truth. And that is what the whole idea of a physician being responsible is the wrong way to go, or the health plan being responsible. It's individuals, and that's the way America is. It's like individual responsibility. That's the thing we need to promote.
Thank you.
So any questions?
So, do you have any questions for either of us? Any thoughts or comments? Questions? Yes, back there.
I have a question about prevention. If I remember this correctly, I think it's between 60 and 70% of like all of the person's money, the money that goes towards saving their life. It's like, in terms of like dollar allocation, 60 to 70% that's spent on a person is spent in the last 6 to 12 months of a person's life. Mm-hmm. So I was wondering if someone was taking preventative measures as they were getting older, wouldn't those costs, they wouldn't have been so high?
Well, I'll say something, Dr. Eck. One thing that I would say is every one of us is going to die. I just want to, lay that right there on the table, right? So the last 6 months of life are going to be there no matter what. And whether or not someone has, less costs on their way to dying, I'm not sure whether that's going to depend on them preventing, because you can't prevent death. So whether or not that's going to, prevent something that'll keep those costs less, I have no idea. What I do think, though, is that we have a system, particularly with Medicare, where there's no, it's like if you go out for supper, right, and somebody else is paying the bill, then you don't really care as much what the costs are. We have a system that encourages more expenses that maybe people wouldn't actually pay money for if they had to pay some part of it by themselves. And so there are things that can cut costs even at the end of the year, at the end of life, if there's some portion that's going to be paid for by the individual and by the individual's family as they start thinking about that. Go ahead.
Yeah, I think probably the biggest expense that is preventable at the end of life is when they prolong the dying process. And that's hard to actually pinpoint exactly what that is. And doctors, we have our experience that tells us when, this patient has started the course, they've had a massive stroke. If you put them on a respirator, you keep them alive for another 2 months, and that'll cost the system a whole lot of money. But they had a massive stroke, and perhaps the kindest thing to do is to let them go. Hard to actually quantify. Government can't dictate when that is. You've got different families who have just different ideas about what needs to be done. But usually the doctor has a good influence on just saying, and actually giving the permission to the family to let go. They feel guilty if they say, well, all right, just, pull the plug. That's not really what you're doing, but you're just allowing things to just take the normal course. You're not prolonging the dying process. I'd say that's the greatest reason why health expenses at the end of life are the most expensive. Has nothing to do with wellness.
Anyone else? Yes, sir.
So do you run into doctors that do support these federally mandated programs, and what are their arguments for why it's a good thing?
Mostly the doctors that I guess the doctors that we run into are probably of two veins for those that do support it. One, just because it feels good. It's a good thing that they can say to their patients. The other is just because they understand that the scoring system, the scoring system that Dr. Eck talked about is the scoring system that we have in Minnesota. Actually, it's 5 things that doctors get scored on. They get scored on the A1C level, the cholesterol level being within a certain range, the blood pressure being within a certain range, whether the patient stops smoking, and then whether the patient, if they're supposed to take 1 aspirin a day, took it. And these are things, as Dr. Eck said, what the doctor's getting scored, but the doctor can't be there every day to say, take your aspirin today, right? So sometimes I think that the doctors who do support it are worried about the whole scoring system, and so they support it with the idea that this is how I'm not going to get my pay docked. But the other doctors that support it are in the system, sort of in an administrative or a higher management position, or they're within the health plan, or they're within the hospital system, which is dependent on the whole scoring system for getting more money. But I do run into lots of doctors who are like, I don't have enough time. Actually, I ran into a doctor who they're just getting their electronic medical record system that's mandated now by the HITECH Act. Well, sort of mandated if you don't want your pay docked. And the staff told me that they're going to get 7 more people to work at the office in order to do the electronic medical record, because the doctors do not have the time to actually input the data. So they're going to, it's a 10-doctor practice, they're going to hire 7 more people just for the electronic medical record. So when we think about adding on prevention as well, besides what that patient came in for, you know, it's incredible because there's not enough time.
As a practicing physician, I'm thinking, if I got to hire 7 people and they're going to lower my pay by 2 or 3%, I think it's a no-brainer. I'll lower my pay by 3 or 4%, because what I'm interested in, to not take it, or no, just to not do that wellness stuff and
right,
send
but
in
then
that
the
information.
Medicare will decrease the pay. So
by 2 or 3%,
yeah.
But that's all right compared to paying all those extra staff.
Right.
Plus, I really do worry about the privacy issue. I think it's extremely important. Patients are not going to be honest with you and tell you what has gone on in their life, which could affect their health, if they know there's 2.3 million people that might find out, including your mother. So I think that it's a very dangerous thing for the healthcare system for this privacy issue, and I won't do it. Part of the Hippocratic oath that we take when we graduate from medical school is to keep all of our information between the patient and us private, and we're just totally decimating that with Obamacare. So I will stand here and say that I probably will not comply with it.
Another question back. Oh, here, let me just get this woman's.
Given that this is a complex battle of ideas and that on the national level it's usually reduced to mere sound bites, and I know you spoke about getting to the root problem of poverty and addressing that at the community level, but how do you respond to the criticisms that it doesn't matter because there will always be poor people, there will be people in lower income brackets, and while you could deal with those root problems, they have medical issues now that need to be dealt with, and there's some responsibility to finance those when it's just mere sound bites? How do you respond to that?
Let me tell you about our free clinic. Everybody volunteers there, including the doctors. And what we're proposing in New Jersey is for doctors to donate 4 hours a week to a place like that, doctors of every specialty, where those poor people who are sick would get to see the doctor of any specialty they needed. And we're asking the state to give us medical malpractice coverage for our entire practice as the only protection. Therefore, it wouldn't cost the state anything for these clinics. They'd be run by volunteers, they could be run through churches, they could be run through community centers. Non-government free clinics is what we're talking about. And there's baby boomers that are retiring 10,000 a day right now who are going to have time on their hands. They've got skills. They could be helping to run these free clinics. We find that we have no shortage of volunteers to do that, and the poor do get cared for. The Medicaid office actually sends us patients because the people who are enrolled in Medicaid can't find a physician. We think it's a far better system. It's working its way up the legislature in New Jersey. There's about 6 or 7 legislators that are interested in signing on to it, and they're writing the bill. So pay attention to New Jersey.
Yep.
If I may, if I just throwing out a random scenario, say we have a poor woman who lives in a rural community, has, 4 children, she's raising them by herself. She doesn't have transportation access to a clinic like yours, which I'm sure does wonderful work. And if $80 comes into her hands, she's going to spend it feeding, dressing her children herself, instead of getting a mammogram. Now, that scenario repeats itself countrywide, all over the place, every day. And she gets breast cancer. She doesn't know. It's too late. It's metastasized. Is she a casualty of this health freedom? Like, what happens to her?
No, not really. If she's coming to a free clinic that's not costing anything, and people get rides.
But if she's out,
they get rides.
Where she can't get to you or any clinic like that, that isn't.
There are little churches everywhere. I mean, there are places that could have a couple of rooms where doctors could be volunteering to help those people. I don't think transportation is the huge problem. And I think a caring community that cares about that woman, she's really not alone, is more important than somebody paying for her mammogram. Because she needs support in lots of ways.
The other thing that I would say is there's lots of women who have lots of money who don't get a mammogram.
Absolutely.
Yeah, because it's not important to them, or they don't want to take the time of the day out, you know. So a lot of it will have to do with priorities. And as an ER nurse, I've been an ER nurse, and then I've been a school nurse, and I have watched that community of poor people or people on Medicaid make decisions. And I have seen them make decisions, even though it was completely free for them to go to the nearby hospital to get the stitches in their child. I've seen them make the decision that that wasn't important. You know, because it was totally free. They had Medicaid, they had everything. The hospital was just, you know, maybe a mile down the road. They knew the bus system really well, but it wasn't important. So people of every class will make decisions about what's a priority and what isn't, and it won't necessarily be, as you say, a casualty of freedom. It'll just be their decisions and what they decide to do and what they decide is important enough to go after.
And by the way, sometimes we have actually, through our free clinic, paid for mammograms. So if there's somebody with absolutely no money that needs one, we'll make sure they get it.
Yes.
I have a question on your thoughts on the sustainability of the current healthcare system. It's like 1/6 of our GDP, and a lot of people think the costs are just rising so much and it's unsustainable. Do you think that something needs to be done in order to lower costs? And like, if you don't support the Affordable Care Act, then what other method do you think will help mitigate that issue?
Well, I can answer that. In New Jersey, $10 billion is spent on Medicaid, $28 billion total budget. So it's a third of our budget. If you've set up a free clinic system and just protected the physicians, you would lower the cost of health care for everyone. They wouldn't be doing all the unnecessary tests they do defensively. It'd be a huge difference. And the economy would rebound. You're taking $10 billion, put it back into the private sector, let them start jobs. The economy would flourish, and the whole healthcare system costs would go down. I think it's a better answer.
I think one of the big problems has been the emergence of the HMO. And for those who may not understand this, and there's definitely a Minnesota connection to the emergence of the HMO, because I can't remember the guy now who got it on the plane with the staff, the healthcare policy staffer of President Nixon. And Medicare was enacted in 1965, and immediately there was like this run on the Treasury. So the prices went up at hospital. Surgeries were done 2.5 times more than they had ever been done before Medicare. Physician prices went up, I believe, 300%, and hospital prices went up like 500%. So everybody saw this really big pocketbook called the government, right? And so the government was trying to figure out what to do. Well, as it turns out, the person in Minnesota who was really into HMOs, which is the birthplace of the HMO, happened to get on the plane going to Washington, D.C., and happened to sit next to Richard Nixon's policy person, and spent the entire trip talking about the HMO. And so in 1973, we got the HMO Act of 1973. And $375 million was given to develop HMOs across the country. And all employers with 25 employees or more were forced to offer the HMO. And then the premiums were subsidized by that $375 million. And what that really did was it changed the entire landscape of medicine or insurance across the country. And I did an article called Blame Congress for HMOs, which talks about the history, and it's right on our website, www.cchfreedom.org, and it's right on the homepage. And now what you see as the impact is you see the consolidation of insurance across the country into managed care organizations. And you see what has happened in Minnesota. This is a good example for you. Big in the news in Minnesota this legislative session is the fact that the health plans receive $3 billion a year from the state of Minnesota, and nobody has any idea where it went. Because there's no accounting for how much actually went out in real actual patient care dollars. There's just this $3 billion that comes in capitated fees, and then the health plans say, well, we did thus and so, but there's really no accountability. And the other thing that has happened is that, as you probably all know, the HMOs in Medicare Advantage receive somewhere between 12 and 18% higher or more per beneficiary than in traditional Medicare. And I find this really interesting because Medicare Plus C, which was the pre-Medicare Advantage, Medicare Plus C, when the government said, we're not going to pay you more, the health plan just dropped out and left their patients, stranded. And they had to go back to traditional Medicare. So if we move the entire Medicare, Medicaid market into HMOs, I really believe that what will happen is that government will be held over the barrel. Government will not be able to run the system on its own, and they will be dependent on the health plans as the government contractor. And then the health plans will continue to ask for and require a certain amount of payment, and then if the government doesn't give it, the taxpayers don't give it, then the health plans back away and say, well, we're not going to run this system for you. And of course, that'll be a huge political debacle. So when I think about sustainability of the healthcare system, I believe we have got to get back to individuals. I would like to see individuals having lifelong policies. I would like to move out of the Medicare system. There's no reason for me having paid health insurance premiums my entire life to suddenly not have that health plan or that health insurance company pay when I really need it, but to go on the dole, as it were, when I turn 65, and then it's all about political decisions as to whether my healthcare gets rationed out from under me. And when I have the money and when I have the policy, I will make different decisions. And it will not be the government's problem. It will not be this $38 trillion unfunded liability. It will not be the $500 billion taken out of Medicare through the federal health care reform law. It will not be IPAB, which is set to ration care by cutting or eliminating payment for care. This is all what's coming as a result of the government getting into the business of health care, when I should be able to, I could do it much better and at a lower cost myself. This is not like an immediate answer. There are tons of people who are so dependent on Medicare, but if you want to protect your life and do it at a lesser cost, it is about having control over the dollars, because money talks. He who has the gold makes the rules. Yep.
Can you speak to the one-size-fits-all preventive programs, which seem to be based more on propaganda than science? I think that you mentioned the low cholesterol screening program, because the saturated fat hypothesis, cholesterol hypothesis is being challenged all over the place. But the government and all their minions are pushing that as a one-size-fits-all. That seems to be possibly counterproductive to human health. So could you speak to that?
Well, I can't speak to that. Maybe Dr. Eck can. The only thing that I will say is one thing that Doug Elmendorf, the CBO, said was prevention could possibly save some costs if it was targeted just at the people who needed it. But he did say, but it's really hard to know exactly who needs it. And so this becomes very difficult. So if you're just going to require cholesterol screening for everybody, it's incredibly expensive, because only a few people will really derive the benefit compared to all the money that you put out trying to test everybody.
And to speak to that, they have protocols that they want everybody to follow, and they keep changing as science changes. And we've learned so much about the metabolic syndrome and what's the cause of heart disease, and it's very, very multifaceted. Cholesterol is just one little part of it. So I bet you those guidelines are going to change, and then suddenly they're going to go, oh, well, we used to make you do cholesterol, but now it's some new test that we're going to recommend. And I don't think the government really should do that. Let medicine advance the way it's been advancing, and let the doctors treat the patients.
The one thing I'll just tag on to that is what really concerns me about protocols and so-called evidence-based medicine, and I did a report on this that just showed how it's harming patients and leading to rationing and really slowing up medical innovation. But one thing that really a lot of people don't think about is when the government tells the doctor how to practice, it's the government practicing medicine on a patient they don't see and aren't responsible for. And so what we have here is a movement away from physicians practicing medicine to government forcing doctors, or government practicing medicine without a license. And they have no responsibility for the patient. They don't know the patient by name. They know nothing. It's just this protocol put on their computer screen, and every decision that they make is tracked according to what they do. And so we move into a spot where you as an individual will not be treated as an individual, but will be treated in one-size-fits-all medicine. So that if the doctor is going to treat you differently, they have to actually write the reasons why, which takes up more time. It provides more information about you on a medical record that goes everywhere. And it really just says that the doctor who has had 13, 15 or more years is being micromanaged by a government who doesn't even know the patient. So that's a very big concern for us. Anything else?
Thank you so
coming
much.
to the end?
You've been a great audience.
Thank you very much.